My name's Andrew Lawrence. I'm one of the Deputy Directors here at the Florey. I've been here over 20 years now, and I run the Addiction Neuroscience Lab, which is part of the mental health mission here at the Florey. For many years, my research has focused on understanding how alcohol and other drugs impact the brain so that we can identify new treatment options to help people with addictions. I think, we know it's an enormous public health problem out there, not only in Australia but around the world, and it's been overlooked for far too long. And for one, I'd like to be able to make a difference to people in that space. At the outset, before we get going tonight, I'd like to acknowledge the traditional owners of the land where we're meeting today, the Wurundjeri people of the Kulin Nations, and pay my respects to their elders past, present and emerging. And I'd also like to extend that respect to any other Aboriginal and Torres Strait Islanders peoples that are here with us today. So welcome, you're very welcome. It is your land, and we're just on it, but with your blessing, hopefully. Today we have a fantastic lineup of speakers for us to learn from, and I think the attendance here, the great crowd here today, is testament to how important mental health is in our everyday lives. I'm sure we all have a personal connection to mental health conditions, be that firsthand as an individual or through a friend or family member. I know I do, for one, and I'm sure most people do. We're not going to ask you to put your hand up and say, my name's so-and-so, but that's fine. I think we all know where we're at in this space, and I think it touches everybody in every walk of life. For those who have been to our public lectures before, it'll take a slightly different format this time. We'll start off with a short presentation, about 15 minutes, from Professor Ashley Bush, and then we'll introduce our panellists. So without further ado, let's welcome our presenter for today. It's my pleasure to welcome a good colleague of mine, Professor Ashley Bush, who is a practicing psychiatrist here, and he's the clinical lead for the mental health mission at the Florey, and he also heads the oxidation biology group. He's responsible for discovering the role of a number of different metals in the biology of neurodegenerative brain disease, and has provided insights in this regard into Alzheimer's, Parkinson's, as well as schizophrenia and other brain conditions. Professor Bush is going to be introducing us all to the topic of mental health treatments with his first-hand knowledge of being a practicing psychiatrist. Thank you, Ashley.
I am, as Andy says, a practicing psychiatrist, but I'm also a credentialed neurochemist and spend a lot of time dealing with molecules in animals and tissue. And I thought you might be interested to hear how I came about to have such an interesting combination career. So I thought a little bit of my biography might be of relevance as we go along. First, I want to set the framework of how big the problem is that we're dealing with in terms of mental health and psychiatry. In the past 12 months, 1 in 5 Australians will have experienced a mental health disorder, and 1 in 7 children and adolescents will experience mental illness. And throughout a lifetime, 2 out of 5 Australians will have experienced one of the mental health disorders. So these are very, very big numbers. And it was into this world that I entered as a psychiatrist, and I began my training after doing an internship straight into psychiatry training at this institution, Willsmere Hospital. This is a picture of the hospital which was established in 1849 and it was called previously the Yarra Bend Lunatic Asylum and the Kew Asylum. And that's a picture from the 1890s or 1900s, and a more modern photograph where it's now high-end residential property. I began my training in 1983, and I was handed a set of keys such as those that you can see there, like a big set of old Victorian keys which were used to lock the doors of the wards in this place. And I was exposed to 600 people who were locked away in this asylum as a young registrar. And I did my training there. I was actually I received tutorials from Eric Cunningham Dax, who we have an art gallery named after. And he was a great lover of art. Now, Willsmere, which was called the Kew Asylum, was in an interesting location in Melbourne. It was it was founded in 1849 at a bend of the Yarra River. You see an old map of the Kew Asylum there in the bend of the Yarra River. And in the early days of Melbourne, if someone became mentally ill, they were put on a punt and they were taken down the river in the direction of this bend, and they went to the Kew Asylum. And it's from that we get the expression to go around the bend. Thought you'd find that to be a bit interesting. Towards the end of my training in 1988, I was introduced to this gentleman, Professor Colin Masters. Professor Masters is one of our senior faculty here at the Florey Institute now. In those days, he had just moved from Perth to Melbourne to take up a chair of pathology at the University of Melbourne. And I had the opportunity to be his first PhD student in Melbourne. And it was a very interesting PhD. That's a nice photograph of Colin in his natural element. What he's known for is discovering the composition of the spots that accumulate within the brain in Alzheimer's disease called amyloid. And he made that discovery in 1986, and I met up with him and started my PhD with him a couple of years after that when he had moved to Melbourne. But the discovery of the accumulation of this material in the brain in Alzheimer's disease and what it was composed of automatically led to the concept that there might be a therapy there by clearing this material out of the brain. And the question was how to do it. And if we fast forward nearly 40 years, we finally have a drug that can do this, which has been launched in the United States and will, I hope, eventually be launched and available for prescription in Australia. This is the first disease-modifying drug for Alzheimer's disease. And the reason I mention this, because Alzheimer's disease is a little bit out of what we're going to be talking about tonight, but the point I wanted to make is that it was a 40-year journey from the original discovery to having a drug available on the market that can do something about the disease. And it gives you some idea of the time dimensions that are involved in neuroscience research. These are not easy diseases to evaluate and to create new drugs for. And so we have our work cut out for us to be able to make an impact on these very, very prevalent and devastating disorders. I list here a cluster, it's a simplification of the major psychiatric diagnoses: anxiety, depression, bipolar disorder, personality disorders, schizophrenia, attention deficit hyperactivity disorder, and substance use disorder. There are other categories, of course, and within each one of those groups there are subgroups. The anxiety disorders, for example, include post-traumatic stress disorder, social anxiety disorder, panic disorder, generalized anxiety disorder. So there's a lot of granularity, but those are the simplification. That's the big picture. Now, the mental health care situation in Australia is delivered by a variety of modalities, and these include, at the front line, the general practitioner, who does most of the prescribing for mental health disorders, and I'm going to show you the statistics on that in a minute. Then there is community assessment and treatment teams, support groups, psychologists, psychiatrists, residential care, hospital care, both inpatient and outpatient, emergency department care, and of course there's the NDIS, which plays a very important role in supporting people with chronic conditions. We can divide mental health treatments into two broad categories. There's the non-medication and the medication side. And the non-medication approaches include lifestyle modification with sleep, exercise, and nutrition, community support groups, cognitive behavioral therapy, other forms of psychotherapy, and the medication approaches are categorized into various groupings such as antidepressants and anti-anxiety drugs, antipsychotic medications, mood-stabilizing medications, and hypnotics. I'd add psychostimulants to that list as well, very important for ADHD. And in the financial year 22-23, 4.8 million people filled a health-related prescription in Australia. And here's some very interesting statistics about who is doing the prescribing. And what these data come from the Australian Institute of Health and Welfare, and they show the number of prescriptions given by either general practitioners, non-psychiatric specialists, or psychiatrists. In terms of the different groupings, antipsychotics are mostly, well, in each one of these groupings, except for psychostimulants, the general practitioner is the most common prescriber. For antipsychotics is the most common prescriber, anxiolytics, most common, hypnotics and sedatives, most common, and antidepressants is a rather remarkable excess. Nearly 31 million prescriptions for antidepressants in the financial year 22-23 were made out by general practitioners, compared to only 1.7 million that were actually prescribed by psychiatrists. So you can just see the important role that general practitioners have in terms of the trends of prescriptions. The only category of drug where psychiatrists are actually prescribing more than general practitioners are the psychostimulants. So if you have a look over the last 10 years at the trends for prescriptions, the number of mental health related prescriptions per 1,000 people is basically 1.5 to 1 in 10 years ago, and has risen to close to 2 to 1. So 2 prescriptions per person in the country per year. So it's a lot of prescriptions. There is a gigantic amount of prescribing that is going on for mental health conditions. So what are these conditions? I'm just going to hit the high points on 4 examples. Anxiety disorders. So the available treatments for the anxiety disorders include psychotherapy, cognitive behavioral therapy, treatment with SSRIs, which are a class of drug that elevate a chemical called serotonin within the brain, and benzodiazepines, which are sedatives. And the limitations of these approaches is that there is a tremendous amount of treatment resistance, so that people can be treated with these approaches and still be chronically unwell with the symptoms. There's also the time and expense of the psychotherapies, and the dependency that can occur with some of the treatments, such as treatment with the benzodiazepines. And then there are withdrawal symptoms. So when using an agent like an SSRI, the drug has to be taken long term, and it's not possible to just abruptly stop it without experiencing severe withdrawal symptoms and feeling very uncomfortable. In the treatment of depression, there are more options, and it's we depend less upon psychotherapy for the serious forms of depression and more upon medication. And the medications that are used are, once again, the SSRIs that elevate serotonin, the SNRIs that increase norepinephrine in the synapse, SDRIs that increase dopamine in the synapse, the NASA class, which increase both norepinephrine and serotonin availability in the synapse, and the MAOs. These are drugs which block the monoamines, and so they increase all of those molecules that I mentioned before in the synapse. And this is the general approach in terms of antidepressant classes that are used. In addition, we can augment these treatments with other agents, such as treatment with antipsychotics, with lithium, with thyroxine. And apart from the medication approaches, there are physical approaches, such as ECT, which is a very important modality, electroconvulsive therapy, in the treatment of severe depression. And TMS, transcranial magnetic stimulation, is used more and more. Over the last 10 years, there's been quite a revolution in the use of TMS in the treatment of depression. And then finally, I'll make mention of the psychedelic therapies. The first one has just become approved for use in Australia through a TGA mechanism, and that's with MDMA, and that holds some potential in terms of treating certain types of depression. Now, there are lots of limitations in terms of these physical approaches. There's treatment resistance and ineffective treatment, which is the most common problem, which affects about 30 to 40% of cases of depression, who go on to have chronic unhappiness and depressive symptoms which don't remit with these treatments. There's also withdrawal effects that I mentioned before. These drugs are given over periods of months minimum in order to have benefit, and they can't be stopped abruptly because they cause neurochemical changes within the brain so that the brain becomes dependent upon the presence of the drug. And when stopping the drug, you have to actually titrate it slowly downwards rather than stop it abruptly, or else you get withdrawal symptoms. Then there's relapse and chronicity. As I mentioned, you've got treatment resistance, but also even people who respond to the treatment are at greater risk of having another relapse and have multiple episodes of depression throughout their life. There's an increased risk of suicide, obviously. And then there is one of the age-old problems that we have in psychiatry is how much of a depression is an actual personality problem. So is the difference between depression as a medical syndrome versus ordinary unhappiness and personality problems is always a problem that we have to keep in mind. Schizophrenia is a dreadful disorder which affects nearly 1% of the planet. It's mainly treated with antipsychotic classes of drugs which block the dopamine D2 receptor within the brain. And that's been the mainstay of treatment for the last 75 years in terms of what we have as the major treatments for schizophrenia. But other things are used as well that include ECT. We treat the anxiety with anxiolytics. And we treat the comorbidities, the other problems, such as anxiety and depression, with antidepressants and benzodiazepines, because these are complications of the schizophrenia syndrome. Now, there are a lot of limitations to these approaches. The antipsychotics are imperfect drugs. They have a lot of side effects, and each patient has to learn how to deal with these side effects. Some of the issues include weight gain and diabetes, Parkinsonism. And in addition, schizophrenia is quite often a chronic disorder, so it can have relapses in terms of episodes of psychosis, and as well as that, it has a chronic deficit syndrome where a person becomes disorganized and has cognitive impairments, which can make them more and more dependent upon care as they age. And in fact, it's recently been reported that schizophrenia can actually cause a dementia if you live long enough. Currently, we have very little to address the cognitive deficits that occur in schizophrenia. So that's quite different to the psychosis part of schizophrenia. People with schizophrenia also have difficulty doing ordinary cognition and calculation and reasoning. And there is a drug on the horizon which is called KarXT, or xanomeline, which is a completely new class of drug that has gone through successful phase 3 testing and has been put forward to the FDA for approval for use in the United States. So hopefully that drug is on the horizon for us to be able to use in schizophrenia, because that does seem to have an impact on cognition and other facets of the disorder. And importantly, schizophrenia itself shortens lifespan, not just from obvious things such as the increased risk for suicide, but also because of problems that have to do with cardiovascular disease and poor general health. The lifespan in schizophrenia is shortened by about 20 years. And finally, bipolar disorder. This is a disorder which is about half as prevalent as schizophrenia, but is a major problem for people. The current treatments are lithium as the major drug. Of course, lithium was discovered in Melbourne by John Cade and published his first paper in 1949 on this. And the other treatments that are used are antipsychotics and mood stabilizers. We call them mood stabilizers, but what they are actually anti-epileptic drugs. And they happen to stabilize mood, and we use them off-label in psychiatry a very great deal. And also ECT plays a very important role in managing bipolar disorder as well. The limitations of these approaches, well, the drugs carry lots of side effects. Lithium is a fantastic drug, but has a very narrow window of efficacy beyond which it becomes toxic. So we constantly have to do blood levels to avoid damage to kidneys, thyroid, and other metabolic changes. And the antipsychotics, as I mentioned before, they're plagued by side effects such as weight gain and diabetes and Parkinsonism. Bipolar disorder is prone to relapse. That's hence its name. We have ups and you have downs. And it is, in more cases than not, a lifelong affliction. And like schizophrenia, it also shortens the lifespan. And this is considered to be largely due to increased cardiovascular disease. And another interesting limitation about bipolar disorder is that although bipolar depression is the most common pole of the disorder, representing about 60% of the time when the person is symptomatic, antidepressants don't work in bipolar disorder. So we have to treat patients with different things, and we struggle to know how to treat the severe depression that occurs in bipolar disorder. Okay, well, that's been a bit of a tour of a very major subject, and I probably haven't done it much justice, but I've tried to touch upon the high points, and I'll now hand back over to Andy.
Thanks very much, Ashley. What a great introduction to what we're going to be speaking about now as a panel today. We're going to bring up our panellists. I'm going to take a seat as a moderator, and then we'll start some questions. So please come up and take your seats. Okay, so we can see from the slide just above how we can gain from understanding the underlying biology of mental health conditions. We can have more effective, more targeted medications. We can develop preventative strategies for mental health conditions. We can also have a greater understanding of how genetics and our genes inside us play into mental health conditions and identify people at risk. So those are things that we strive to do here with our research. There's a lot to unpack in all of these elements, and this panel is going to help us do just that. So we already know Professor Bush as psychiatrist and prolific researcher in the neuroscience field more broadly, and particularly, as he said at the beginning, in the field of neurodegeneration and dementia, with a particular interest in Alzheimer's disease. Sat right next to Ashley is Professor Anne-Louise Ponsonby. She's an epidemiologist and public health physician with extensive experience in population-based studies that look at genes and environment and how they interact with each other. Anne-Louise is head of the neuroepidemiology group here at the Florey. Right next to Anne-Louise is Dr. Draper-Joyce. He's co-head of our Drug Discovery Innovation Lab, which focuses on developing innovative strategies that facilitate the development of next-generation therapies. And right on the end there, last but certainly not least, is Dr. Thibault Renoir. He leads our Genes, Environment and Behaviour group here at the Florey. His team examines how gene and environment interactions influence both neurodegenerative and psychiatric disorders, including depression, anxiety, schizophrenia, and obsessive-compulsive disorder. Okay, so I'm going to open up with some questions for the panel. Okay, Ashley, this first one's for you. We know that developing these medications takes a long time. We'll bring up the graphic now. On average, it's around 27 years, but as you mentioned in your talk, it was almost 40 years for an anti-amyloid treatment. And obviously this because of a very necessary, rigorous process involved in drug development. What does this overall process look like from start to finish, Ashley?
Well, there is we have the slide up there, which does actually quite nicely illustrate what the steps are in terms of trying to develop a drug from the very basics. I mean, if you take Colin Master's example, the drug discovery that began with the identification of a target being the amyloid, and then eventually there was the proposition of being able to remove the amyloid with an antibody, but they had to create a model for Alzheimer's disease first, because you don't go straight onto testing to humans. So you test ideally in rodents, usually mice or sometimes rats. And so it had to be developed. The model actually had to be developed in order to be able to see whether the antibody could remove the amyloid. After that was done, then it goes through the preparation to turn it into a drug candidate. That involves a lot of regulatory hurdles to make sure that it's safe, ultimately before it's even tested in human beings for the first time. And then after the first testing, It goes through advanced clinical trials, phase 2, phase 3, phase 3 being very large-scale clinical trials in the case of the Alzheimer drug, which would probably be similar for any of the mental health disorders, involving thousands of people over many years and costing in the order of billions of dollars.
Great, thanks, Ashley. And you mentioned early on in that answer regarding the preclinical research required to test in animal models. Thibault, maybe you want to comment on that side of things?
Yes, of course. Hi, everyone. So first, I mean, when you say how it looks like, definitely long and probably expensive, so we haven't talked about that, but you can gather that it's very expensive exercise. And even though it's a straight line, it's definitely not straightforward. So I'm not a clinician, but I'm going to focus on the early stages, which is drug discovery and preclinical trials. And the idea would be first to understand the disease and try to model the disease. And one way to do that is to use in vitro cell models or animal models, many rodents, which are not that far away from human when you look at genetic and environment factors, and that's very much how we try to model those diseases. So like I say, it's not straightforward. Even though it's pictured as starting with the animal model, we use clinical data. We know what's happening. We know some genes and some people are more susceptible to develop the disease. So we study those genes, we modify those genes in those models, and then we expose them to different situations, comparing what we call standard versus stressful condition, and then we can identify eventually, looking at the brain, some targets that we can target using compounds and eventually follow up this journey.
Okay, thanks, Thibault. So we have a bit of a conundrum. We know, as Ashley said before, around about 1/3 of people don't respond to the current medications. And now we know that it takes such a long time to develop new medications. So is there a way that we can get around that and fast track it? Staying with you, Thibault.
That's a good question. So like you've seen, there's a lot of antidepressants, but somehow there's still 30% of people not responding to drugs. So we need more drugs. And one way to speed up the process is sometimes to use a drug which we know target that relevant target, but used for another condition. And there's a few examples of that. So recently, ketamine, which is used as an anesthetic, it's been now fast-tracked and used as a fast-acting antidepressant. So it doesn't work for everyone, but again, for people we've gone through many antidepressants and don't respond to drug, this new drug that we can start. Basically, we will start already with clinical trials because we know they're safe. We kind of know already the dose which have a therapeutic action, and that's a way to speed up the process. Another example recently, so Ashley mentioned psychedelics. Now we've got some data showing that psychedelic could be also fast-acting antidepressant. And instead of having chronic administration of drugs, we try to have some drugs we could eventually work even acutely and have long-lasting effect. So that's how we speed up the process, I would say.
Okay, thank you very much, Thibault. So Chris, over to you now. If we're thinking about developing new medications and we've got this terrible long time span, can we use technology to fast-track it? Can we use technology to identify and validate targets more quickly and fail things more quickly than we used to? Can you tell us a bit about that?
Yeah, it's a great point, Andy. So I guess in the last 10 years in particular, there's been a huge number of advances in that early stage drug discovery process, to the point that we can now do things at an exponentially quicker speed, at an exponentially larger scale, and move the needle quicker in that early stage of the process. So I guess previously, when we were doing these kinds of things, it was probably more akin to fumbling around in the dark and not knowing the kind of level of precision about both the biological target we were trying to drug, as well as understanding the molecule we were trying to create that would be a potential new drug. Whereas now it's a little bit more like the lights are on and we can do things with the precision required. And I guess to that point as well, we now can use those tools in that early stage of the drug discovery process to also better understand the underlying biology and where things have failed previously. And Ashley made a really good point about the new potential medicine that's on the horizon for schizophrenia, the antipsychotic KarXT. I mean, that's a compound that had previously failed in clinical trials for a large pharmaceutical company, but we now can go back and know why that's failed and where the problems were and why there was a poor kind of ratio of side effects to kind of efficacy of that drug. And that's now been reformulated to for the first time, be a new mechanism for an antipsychotic against that particular disease.
Thanks, Chris. And actually, following up on Chris's example of KarXT and his earlier comment about precision medicine, do you want to just talk briefly how we may be going from a lack of precision in psychiatric medicine towards a more precision medicine environment going forwards?
Yeah, well, I mean, that's where psychiatry envies research such as done in cancer. Where in cancer, there's very great use of precision medicine where you can pick out a mutation that's involved in the particular cancer and dial up a drug that is known to exploit the vulnerabilities that are involved in that mutation. Now, in psychiatry, we're really only at the beginning of the ability to be able to do that, where we're getting some idea of the genetics of the disorders that are involved in order to be able to find targets that might lead to us being able to look at the genetic signature of an individual and be able to then dial up an appropriate treatment to be able to benefit that person specifically.
Thanks, Ashley. That's a great segue into Anne-Louise. Understanding the biology of mental health conditions, Anne-Louise, we learn a lot about genetics. So we know that you're looking at how genes and environment interplay. What have you learned through your work in this regard, specifically in the mental health sphere?
Okay, so, we all know that there are some diseases that are purely genetic, like Down syndrome, or some that are really much driven by environment, like sun-induced damage to the skin. But most of them are a combination of the environment being adverse and a genetic susceptibility to that environment. And often it's not just one environmental factor, it's about 10 or 20 coming into play, risk factors, and 10 or 20 genetic factors. So we call that multifactorial disease causation. Luckily, with prevention, we just have to get under the threshold and understand one or two. So I'm going to give you an example from a grey zone, which is plastics and mental health. So in the literature at the moment, we have a grey zone where mothers that have high plastics in their body, in birth cohorts, 60% show a link to attention deficit, but 40% don't. So this is a grey zone. It's very much worth considering. EU's just started a consortium to research this, and I'm proud to say Florey is one of 4 organisations outside the EU, because of our expertise here at the Florey, that have been asked to join this effort. And we've published 2 papers showing that they're looking at plastics and child's outcomes like attention deficit at age 4, and we stratify the child population by genetic vulnerability to oxidant pollutants. So people have a genetic set point with their antioxidant capacity. Some lucky people have really high antioxidant capacity naturally. They don't need as many antioxidants, and they're a bit more protected against oxidant things like pesticides. We find in the 1/5 of the population that has that genetic vulnerability, then we see much more evidence of plastics being adverse. So it's a complicated interplay, but it helps us to end up finding out disease causation.
Thanks, Anne-Louise. That's a marvellous example. I might just pass back to Thibault briefly to give you some insight into how, in the preclinical space, we model how genes and the environment might interact.
Yeah, so like you heard, it's very complicated and it's multi-factorial disease. So at the genetic point, it's the same. It's not only one gene, but we have to start sometimes. We have to simplify the story to find a target. So from the preclinical point of view, we try to push the system, I guess, to an extreme to find a target, and then we look at behavior and try to model the behavior in the best environment. And again, we're going to find treatment which is going to work for a subset population of patients.
Thank you very much, Thibault. So coming up to the last question here for the panel, and then we'll open it up to you guys in the audience. So we know that mental health throughout a person's life will look different, and I think that would be a good thing for us to learn about right now. Anne-Louise, we know you have insights from prenatal stages, and actually you have insights for our ageing population. What do we know and how can we influence that? Anne-Louise, I'm going to start with you.
Okay. So this paper was just published in this graph in Lancet in April 2024. So it's very recent, and it's showing that intervention in early life can have a major impact for mental health. In the last 2 years, we've published 2 papers on 2-year-old outcomes of internalising behaviour, which is sort of anxious, withdrawn, a marker of often of later anxiety, or externalising, which is conduct disorder, sometimes linked to hyperactivity, attention disorder. And we find that inflammation at the end of pregnancy, high inflammation or high chemicals related to oxidative stress in the mother in the 3rd trimester, predicts those diseases at age 2. So that is giving us a biological insight that we might be able to move to intervention. We might do new tests in pregnancy in the 3rd trimester, pick up metabolomic profiles for pregnant women saying, oh, these things are a little bit out of balance. We'll help you optimise these conditions, optimise your baby's development, and hopefully lead to reduced mental health problems.
Thank you, Anne-Louise. I might step in there as well and talk about something in my own sphere, in my own interest, because it touches on quite a number of the areas we've discussed today. So we've spoken about, Thibault and both Ashley mentioned a bit about repurposing drugs that are used for one indication for another indication, and we've also touched on how long it can take to go from an initial discovery to a treatment. So I told you right at the beginning that one of my big interest is to help people with drug and alcohol abuse problems. And back in 2006, almost 20 years ago, my team was the first group in the world to publish a finding where we demonstrated a key role for a particular chemical in the brain that was critical to drive relapse to drug and alcohol use. And so we've been working on that. A whole lot of people around the world have been working on it, but quite separately, drug companies were working on the same system to develop a new sleeping tablet. A sleeping tablet that would not cause dependence like the benzodiazepines that Ashley was talking about did. So a drug was marketed and registered for use in a number of territories, including Australia, as a new non-benzodiazepine sleeping tablet, basically. So I put my research findings together, knowing that the same target that was being targeted as a sleeping tablet, I believed would also possibly work for people with drug and alcohol problems. So we tried it. And we just published a case report earlier this year. We had a gentleman, mid-30s, drinking 16 alcoholic drinks a day, very unwell, very highly anxious, poor liver function, clinically diagnosed insomnia, not able to sleep. And we treated him with this compound, and 13 weeks later, he no longer had insomnia. He was 100% abstinent from alcohol. His liver function had improved and his psychological scores were back to normal. He no longer had anxiety. So that provides, it's only an individual person, but it provides a proof of concept that we can do things to help people and turn their lives around, and I feel that we should do that. And I'm in a consortium of researchers around the country with clinicians, and I've managed to convince them through a synergy grant that we hold together to start a new trial on that compound with a bigger number of people with alcohol use disorder to see if we can help more people and provide a real push to repurpose this drug, globally, not just from a testing perspective. So anyway, on that point, I'll move over there because that's really kind of a midlife condition I wanted to give you an example of. Ashley, I'll pass back to you now just to talk a bit about mental health in the ageing population.
Well, of course, healthy ageing is a very important area of research where we have made some tremendous advances. And it's well understood now that a healthy body does help a healthy mind in terms of advancing years. Even into the example of Alzheimer's disease, where you can see the spots within the brain, but this is linked to risk factors that are the same risk factors for cardiovascular disease and heart attack. So modifying those risk factors, which we know we can do nowadays with lifestyle changes, as well as with certain preventive medications, can modify the risk for Alzheimer's disease as well. So this is the product of decades of research in understanding the benefits of particular lifestyle changes. I mean, it's not that long ago where we thought that smoking wasn't that bad for you, and it was quite a popular thing to do. And now we understand how completely differently we regard that. I mean, there are numerous instances of that which can be applied to mental health with aging. They're probably too numerous to be able to enumerate right now, but it is well understood that there's much more to maintaining mental health with age than just relying upon medication, that's for sure.
So what I'm going to do now to wrap up is ask the same question to our four panellists and get their insight. So I'll start with you, Thibault, and work my way back slowly towards me. Medical research in mental health comes with its fair share of challenges. What is it that motivates you to work in this space, and what keeps you going? Easy question to finish up with.
Easy question. I mean, what's exciting me, it's like there's a lot of research still to be done. So every day I'm coming and I know I'm contributing to something which needs to be done. The other side of of my job, which we haven't talked too much, is a teamwork, and I'm lucky to supervise students and see the next generation be as motivated as me. So it's passing on the knowledge as well, and seeing that we can still find new drugs, even for schizophrenia, even after like 50 years of trying to understand the disease. So that's why it makes me come to work every day.
Thanks, Thibault. Chris?
Yeah, I mean, I started my PhD a little bit more than 10 years ago, and it's amazing in those 10 years, kind of the rate of acceleration, particularly in that early stage of drug discovery, of techniques and new methods and more sophisticated ways to go about creating hopefully better and safer molecules. So I just find it invigorating to get the opportunity to be at a place with so many really high caliber researchers getting to do stuff that's at the frontier, and like Thibault said, getting to work with teams of people that all share that same goal and same passion, and really get to push the boundaries of what that early stage drug discovery looks like, and hopefully end up making better medicines in the future.
Thanks, Chris. Great. Anne-Louise, over to you.
Right. Two elements. One is the conviction that medical doctors such as myself, the medical workforce, should be engaged in preventing disease onset, that's primary prevention, as well as treating it or chopping various bits off people as they go through the life course. The second is experience. I was very fortunate that I did my PhD on sudden infant death syndrome with Professor Terry Dwyer in Tasmania, and some of our knowledge that was published in journals, international journals, with some other people's work, meant that we saw a SIDS rate reduction of 70% over 2 years. And once you've been a small part, there was a huge team involved. Once you've been a small part of something big like that, you think it is possible, and you would like to see it happen again with some of our particular modern problems.
Great, Anne-Louise, marvellous. Over to you, Ashley.
We'll end off with where I started. Willsmere Hospital left a tremendous impression on me. I saw so many people there with chronic, incurable disorders. And now, decades later, we are making progress, but these disorders are still a major burden. And I felt like I would not want to go into my, as it were, early career as a psychiatrist and just hold people's hands and write prescriptions for drugs that are not working well enough. I felt I wanted to be part of a change to be able to make a dent to improve the outcomes for these problems, and do my best. And the best way to do that was by doing science, to go back to the concepts that are involved and the actual biological underpinnings of these disorders. And I tackled Alzheimer's disease for quite some time, and then moved into schizophrenia and tried to make a dent there. And I think all of us, with every paper that we write, more facts that we put out there, we work in an international community, and I think we hold our heads up high here at the Florey in being able to deliver new facts that can be digested and used to eventually come up with the next generation of treatments for these problems.
Yeah, I think that's great. And that's essentially the same motivation that I have as well. I mean, I have a personally very strong sense of community, and to me, you know, a mature, civilised community is one where people that can look after themselves do so, but they also take it upon themselves to look after people that are less able to take care of themselves. And so I think I can look after myself, and I do, and I also put it upon myself to try and do things to help look after other people, and that has motivated me to not to be a clinician, but as Ashley said, I wanted to go and be a scientist. He was a clinician that returned to science to pursue this, and I think it's science that can give us the answers, and we can give the answers to the clinicians to then help the people. So it's a real kind of team sport. Anyway, I think we'll wrap it up there. Let's have a round of applause for our panellists.